get started now. I'm Joe Naughton-Travers from Open Minds. I know a number of people are signing in at this point. I'm delighted to do the first roundtable for our executive blueprint for crisis management with my friends and colleagues, Sharon Hicks, Hoover, and Ken Carr. Guys, it's great to see you again. I can't wait till we can see one another in person. First and foremost, tell me you're all doing well and that your families are doing okay.
Yep, doing well.
Yeah, me too. And I have family in New York and older parents living there, so it's been a little hairy, but everyone so far is good.
Well, good.
And I'm doing well as well, Joe. My wife works for a health system, and so she's kind of been keeping me updated on everything happening here in Southwest Florida. And as a state, we're kind of beginning to move into phase 1 of opening up. So just been interesting times, but we're all safe and well.
Sure, good. And Leon, you and yours?
Yeah, doing well. We're just, as of Monday, as I guess that's yesterday, this being Tuesday, we moved into phase 2 here in Fresno, California. And we'll see how that goes. So far, so good. But that's just some retail opening up that was not allowed to be open before. All practices, safety practices have to be in place. So we'll see how that goes. We're all wearing masks and everything else. We do have, speaking of parents, elderly parents back in Pennsylvania. We're in California, but we have parents back there. We're FaceTiming or Zooming or whatever works. So that's how we keep in touch. And they're doing well. We're grateful. They're in their 90s.
Well, good. Me and my family are here in Chapel Hill. We've been sort of in lockdown for 8 weeks, so we barely get out at all. So, we feel safe and lucky here. Listen, I'm so glad to have the three of you join me for our roundtable. For the people in the audience, there is a chat box. If you find it on the bottom of the Zoom screen, when you ever have questions, just pop them in and I'll do my best to moderate them. With Open Minds, we put together this executive blueprint for managing through and after this crisis, and it had 7 sort of key points to it. One was the initial crisis management plan, and all the providers on the phone and on the video know this. What do we do immediately to take care of things? The second step really had to do with cash management. And the third piece had to do with virtual service delivery. And then a fourth was virtual. If we're just virtual, how do we get people to come to us? The whole referral process. Then the fifth point was about revenue maximization, which is if our whole budgets are shifting, how do we maximize revenue? 6 is about aggressive business development. And 7, and this is the one I've been focused on the most, is what are we doing for after? How are we preparing for whatever the post-pandemic future looks like, whenever that may be, whether it's this fall or next year. How are we going to get through this time period? And we have so many leaders on the call, actually, on the Zoom meeting. I looked up who was coming to it. And what leaders do well is they lead us through the crisis, and they deal with all the things that are going on. But then they also help us keep thinking about, well, what will it look like afterwards? Will we all be doing telehealth? What will the competition look like, or other sorts of things? So, that's been our plan. And the reason we're having the roundtable is about this broad notion of preparing our providers and other customers for the next step. So what I'd like to do is to go around with the three of you first and just ask a simple question, and then we'll see what questions come up from folks, is what are you hearing from providers? I mean, what are the things that are going on for the last 6 or 7 weeks? And actually, I'll start with you, Sharon.
Okay. I think that everyone right now is in the Winston Churchill phase. We're at war, we're in the middle of the crisis, and people are just dealing with the fact that, London's being bombed every night. So we need strong leadership to decisive leadership. I almost said divisive, the opposite. Decisive leadership, people who are able to show and give us hope during this process. But we are at what, week 8 or 9 of this disruption of the world. And so the next task for leaders is to start moving us into, you know, the kind of post-war recovery while we're still at war. So, you know, he didn't do that great a job, Churchill, after the war was over. He wasn't conciliatory. He didn't understand the kind of extending olive branches across the aisle model. And so that's really where we're going to be. I think this is going to go on for a while. You know, the 1918 pandemic was in place for 2 full years. The death toll in 1919 was higher than in 1918. So what we have to be thinking about now is, what relationships do we need to be building so that we will still be here in 2020? And I think that it's almost that like moral equivalent of war thing. On some level, it's soothing as a leader to be managing the actual crisis, because we know how to be positive. We know how to talk to our staff in such a way that it's reassuring to them. We know how to help them feel confident that we're in charge. I think we're going to need to really figure out how to work collectively in a way that we're not used to doing, and model for our staff how we get into that new collaborative model that's going to assure that this market in total continues to be viable through the crisis and post the crisis.
Sure. So it's that balance. Monica wrote about it yesterday or the day before, of taking care of the now, which is the crisis, but simultaneously as leaders, we have to be planning for that next step. So Ken, tell me your perspectives on what you've been hearing from providers. What are the big things that they've been wrestling with, other than suddenly doing telehealth or some of the obvious stuff? What are your notions?
You know, what I'm seeing pretty much throughout the contacts that I have is that everybody's waiting for someone to tell them what's going to happen next. A lot of passivity out there. There's a lot of, well, are the payers going to come back and then help us regain our cash position? Is the state or the federal government going to jump in and save us? And I actually am not seeing a lot of planning. I'm seeing a lot of anxiety.
Sure. Yeah, I think
that there's going to be some savior, and I'm not sure that hope is valid.
Yeah, the trick for us is to move from reactionary,
exactly,
which we've probably done pretty well, to the, you know, planning piece. But
right.
let me turn it to Ken Carr just to get his perspective on what you're hearing from folks, Ken.
Yeah, and Joe, I think we're a good 30 to 45 days into this crisis. I think if we go back 30 days ago, there was just such uncertainty. But I know teams that are still, executive teams are still putting in 7 days a week, still dealing with issues coming along. And I think that in itself, I remember in Monica's first presentation on entering into this blueprint, her admonishing leaders to make sure that they take care of themselves. And so I know a lot of people have been dealing with how do we work with clients? If we got a residential facility, how do we keep people safe? How do we keep our employees safe? How do we write all these policies, telehealth, all of that? If you're 30 to 45 days into this, I think one of the things is, you know, as a reminder to the executive teams, and I'm hearing folks say, yeah, I think we've made it through this first stage. Make sure you take care of yourself. I think that's the first thing. Secondly, there's really no blueprint for this. We can look to history to try to figure out where we go. But day by day, as leaders, we're figuring out as we move ahead. But as we deal with the day-to-day, it's keeping focus on that strategy. And I know we're going to talk a bit about that as well. But those are the 3 key things that come to my mind as I hear from teams that are pretty worn out already, but we're just rounding the first bend of the race. And so that's kind of where I see things based upon what I'm hearing.
Yeah, no, Ken, it speaks well, certainly, to the wonderful CEOs I know that are customers or previous customers. Some of them I haven't spoken to in weeks because they are buried in the 18-hour a day, 16-hour a day, multiple days per week. But let me turn it over to Leon to just give you, Leon, give us your sort of high-level perspective of what are providers wrestling with. What have you seen both as a CEO and knowing all the CEOs there in California?
Yeah, thanks, Joe. And I would ditto the comments that both Sharon and Ken made. And just to add to that a little bit, I've kept in touch. I used to serve on the provider board here for the state. So I have friends here around the state serving in CEO roles, and I've kept in touch with a number of them. What I think is really settling in to some of the comments you made, Ken, the teams are starting to settle in. Okay, this is not going to be a 1 to 2 week kind of a deal. Because, at first as well, okay. But as it really settled in, I'd say the end of March, beginning of April, like we are in this for the long haul. California shut down pretty quickly, particularly the Bay Area. So they're now looking at the long term. How do I manage through this? And what about the long term, particularly the larger organizations? I see some smaller organizations that are really struggling, cash flow, those kinds of things. The large organizations had more resources, so they have a little more room to maneuver. And the word that comes to mind, which I've used for a lot of years, is leading in ambiguity, because there's just a lot of ambiguity right now. And that to me has always been an important word. And to me, I kind of enjoy that. I like to strategize and figure things out. And how do we do that? But if we're comfortable with ambiguity, we want data. We want all the data that we can use and make use of, turn into information. But it's to be agile, we will need to be comfortable in that ambiguity, because as both Sharon and Ken were saying, we don't know what the other side of this is going to look like for sure. We have indicators, I think, at this point. We'll get into some of those, but that's what I'm hearing right now, Joe.
Well, you know what? I love that concept of leading in ambiguity. I don't know that I could do it well because I don't like ambiguity, but it does fit in with some of the things I've been talking to my customers about, which is, at Open Minds, we talk about strategic planning, scenario-based planning. And one of the things I've started to talk about with my current customers is scenario planning for the pandemic. What if we can open up our day programs in September? What will that look like? How will we do that? If we can't open them up until next year, what would that look like? If we can never open them up again, what would that look like? So I guess my way of structuring ambiguity is to come up with the what ifs. Mm-hmm. But on that note, I actually wanted to turn to Ken, because one of the things I'm both personally aware of, and certainly my customers are aware of, is we could, as I mentioned, we could retool our budgets based on assumptions that things will open up in September or next year, or that, we'll do telehealth, or we won't buy a new building, or all those sorts of things. But what I'm actually finding in the short term is that all that really matters is cash and credit from a provider standpoint. You just need to be able to make payroll, and you hope you already have a credit line because you can't get one now. But I wanted to turn to Ken, because I know you just did a whole webinar in this series for us. I mean, what are your perspectives on that? What are you hearing from providers? What should we be doing?
Yeah, we did a webinar about a month ago. We did it early on in the crisis because we knew that cash was going to be so key. And in addition, as you say, to just reforecasting your budget based upon new assumptions, that managing of cash is so key. And in the webinar, we talked a lot about, we're looking at internal sources of cash and then looking outside the organization as well. But really starting by looking inside the organization and managing cash very aggressively. We typically have a budget that we put together, and we're going to reforecast that, and we look at our financial statements monthly. But a lot of us don't have a very detailed cash budget. And in a crisis like this, you need to create a cash budget that's very detailed, that looks at those cash inflows and outflows weekly, or and helps you identify if you're going to be running short at a particular time, if you need to be aligning credit or cutting some expenses right away. So, creating that cash budget is really key. I think creating a cash flow management team, it doesn't all fall to the finance department to figure this thing out, but to have a team of folks, operations folks, and educate your clinicians on really what are some of the drivers of cash, so everyone is involved in the process. And then really using our metrics, creating those metrics and looking at those daily as an executive team and a cash flow team, those become all very important. In addition to managing cash, I think looking at our receivables, I've talked to a number of providers who know that their revenue cycle management maybe hasn't been up to what they would like it to be, but they've been able to just kind of let it roll the way it has been. But now that cash is so important, they're really looking at how do we get more cash for every dollar service we provide. We can't afford not to do that. So there are a number of sources of cash like that. Really look internally at your costs, maybe delay some of those fixed costs and negotiate with our vendors, how we are going to pay and we're going to pay, slowing down those, reducing our variable costs, that becomes important. Looking for other sources of financing, and the sad side of that is that if you haven't got financing in place now, it's very difficult. And even the government programs, jumping on that right away was really key. So those are all important. And I think the last thing related to cash, and we don't think of it in terms of cash, and I think we'll talk about a little bit later, is really beginning to look at urgent collaborations. If an organization doesn't feel like they have the cash for the long haul, you need to be looking strategically at how do you preserve that mission by combining with an organization for cash. Sure. I think there are a number of strategies, Joe.
Yeah, well, and actually, you and I have worked on a lot of M&A stuff together. I am suddenly seeing this rush for mergers and acquisitions just around cash and credit stuff. But the other thing that occurs to me, Ken, that I was talking to a Kentucky customer, because folks are suddenly billing for telehealth services and everyone's allowed to do it now, and Sharon, you would know this well too, is that the payers may not be ready for the new billing codes and the modifiers and all that weird stuff you have to do in order to actually bill a service people have agreed to pay for. So I've been talking to customers not only about the normal cash projections you're talking about, Ken, but there could be a delay of 1 or 2 or 3 months because the payers' IT systems may not even be able to deal with this.
Well, let me say, the provider billing systems can't deal with that. I think that you have to look at it from both sides, right? So the state comes out with, this new condition code, CR and DR, to indicate COVID, or CPT comes up with a new diagnosis code. All of a sudden, the place of service code 02, which has never been used under behavioral health, is now something you can use. And most of the providers I talk to, their billing systems cannot accommodate these changes very quickly. So you have both the 837 being created on the provider side and then being accepted on the payer side. And just to piggyback on something that Ken said, I don't think that days in accounts receivable, days in AR has been a metric that in general our market has paid a lot of attention to. That may be because historically we were program funded, so people were used to truing up at the end of the period. But that days in AR amount, calculation is mission critical if you're worrying about your cash. Sure. So if you can't submit that bill and then the insurance company takes 2 months to process it through because it's new, or the clearinghouse rejects it because they haven't put the right edit in, that effect on your days in AR could really be tough. So a piece of this is your insurance, are your primary payers partners with you? Or are they adversaries with you? Like, can you approach them and talk about some way to do that?
Prepayments or, advance payments. Yeah. Because I'm
Exactly.
actually looking at some of the stuff, Monica, and I do want to move from cash in a moment here. Some of the survey stuff that Illinois and California did, people have less than 30 days cash. A third of them don't have a credit line. And if it's going to take suddenly 2 months, 60 days in AR to get payments, that'll be a problem for folks. But I do want to change the subject a little bit because I don't want to frighten folks entirely. I'm actually going to turn to Leon. Everyone had to move to telehealth sort of overnight or almost overnight. Some organizations did it in 3 hours, some took 2 weeks. There are some services we can't deliver via telehealth. There are some face-to-face things that have to happen. There are some consumers it doesn't fit for. What's your perspective on this? We've been talking about moving to telehealth in our industry for years. We've moved faster.
Yeah.
So tell me your perspective and what you're hearing from providers, both about the transition, the challenges, and where you think it'll be after this, whenever after is.
Yeah. So let's look at the before, where it was difficult to expand telehealth because you had this whole legal infrastructure you need, you have the financial infrastructure for payment that you need, you have to have your folks trained in how to use it, and your consumers that are comfortable with the modality.
Mm-hmm.
So you put that all together, and what I experienced was when you attempted to expand into other states, frequently the medical societies were very concerned about cross-state licensure, and so it would often stop with that. So we did a lot of telepsych, where I served as CEO, and that was the picture then. I would say CEOs I've talked with, one in particular, who is part of a large physical care system and runs the specialty service line within that physical care system, they were positioned to do this, and they moved an entire system to telehealth in a matter of days. I mean, patients, everybody. I happen to have a sister-in-law who's a nurse in that system back east. And so I know how it worked, and it actually worked quite well for them. So they moved really fast. And I chatted with him a bit and I said, it seems to me that we have done what has happened here is in a matter of a week or two, we have moved from something that would have taken 5 to 8 years to get to, and we've collapsed it into a week or two. And here we are, so many folks. I talked with a smaller provider here in the state of California, and they did not do telehealth before. And within days, they had a system set up and they were able to do it, and they went that direction. In terms of services, yes, there's a variety of things going on. Our daughter and son-in-law, they both operate a private teletherapy service. And so they just kept right on going, and folks came in. So that's one level. Then you have the smaller organization. They had no telehealth infrastructure, but with the platforms that are out there today, they were able to move very quickly and do that. You have the systems that have done it, and they did it overnight. Now, the one CEO in particular said what they're experiencing is what we were just talking about, and that is new codes. Great, okay, you're going to pay us. In some cases, you're going to pay us actually a little bit more. And when will I see that cash? Not so quick, because they're doing exactly what you were saying, Sharon. They're trying to get everything aligned, both on the provider side and on the payer side. It will happen.
But what about the consumers that really can't be seen via telehealth?
Yeah.
There may be consumers with disabilities, other sorts of things. What are you hearing on that front, or how do we address that? Because there's some folks we really have to see face to face, but there's also consumers, that would not do well in this setting. Maybe it's kids with autism, maybe it's other folks with other disabilities. What are your thoughts about that?
Yeah, actually one of the providers has a significant ID service line, and they did a lot of day programming. Mm-hmm. And so most of those folks were not able to participate with telehealth, but what they're doing is using phone. And they are also, and they said folks adapted to that very quickly. They know the folks well, and so they are also doing community visits doing that type of thing, using all the protective safety approaches to it. So what impresses me is how fast most providers were able to change. And we may want to talk about that a little bit later, because we have created, the CEOs, the leadership of these organizations, they have created change in a matter of weeks. As one CEO said, we took our 3-year plan and we executed in 2 weeks. I mean, that was exactly what happened, which now, looking into the future, causes him to ask this question. So why wouldn't we do that in the future? And so I think you're going to see just a lot of change there.
Sure, sure. Well, thank you, Leon. I actually want to turn to Sharon and ask one question to start with. I've had mixed feedback from customers about a demand for services. You know, now that we're in telehealth, you know, are we doing more crisis services, more outpatient, other sorts of things? And what should we expect later? So one question is, what's your perspective, because you've worked for health plans also, about, you know, service demand during and after a crisis? And then the second is about comorbid conditions, because right now, none of us are seeing our primary care doctors. You know, no one's getting anything other than urgent care. So you have two questions. One, you know, give us your perspective on demand for services, because it does affect our customers both before and after. And then how does this integration with primary care fit in?
Yeah, I mean, both, you know, both really important topics I think we could talk about for hours, but
well, you have about 10 minutes.
Yeah, exactly. I think one thing that we have to think through is that the longitudinal effect of this is going to be huge, right? When people are in the crisis, they function. When the crisis is over and people are trying to get back to normal is when all of the post-traumatic stuff comes up.
Sure.
So the fragility of the society is going to be pretty intense for the next, you know, fill in the blank, 5 years, 10 years. You know, this whole generation of kids who graduated from high school this year who never got a high school graduation. We don't know if they're going to go to college next year. That sense of nihilism, that sense that there's no value in doing anything because the world is falling apart has an effect long term. The other piece of this is we definitely, the fragility in the system, in the healthcare system, in the social service system shows up
Sure.
quickly as the economy falls apart. So we're going to have this population of people who are going to be even more fragile. And that may be people with comorbid disease, that may be people who are kind of chronically impoverished, people who work in low-level jobs. So as organizations, part of what we're going to have to figure out is, where is it we want to land? You know, do we want to be the online therapy services that are now exploding and making some money? Do we want to be the kind of, you know, integration of social services, chronic medical illness, and serious mental illness? Because that's going to be a small population, but maybe for the first time, we'll be able to get the right dollars associated with that small population. We've been underpaid for that population for years. So is this crisis an opportunity to say, yes, it's a small number of people with a huge spend. So pay money to take care of them, right? So these opportunities, not everyone's going to want to be in the serious mental illness and, you know, high comorbid physical health space. There won't be room for everybody, but a few people can be there, and a few people will be able to, you know, potentially draw down adequate funds to do that in a way that we haven't been able to do. I think there's going to be significant need. And you know, one of the things that I don't know if it was in the New York Times or the Wall Street Journal, but 243,000 jobs in primary care centers were lost.
Right. I mean, yeah, because, you know, my doctor, the dentist, everyone in hospitals, my sister works for a hospital, if they're not doing elective services, they're in major financial trouble.
Exactly. And so you know, the upheaval is going to create opportunities for us to come in and say, we know how to do this thing. So pay us adequately and we'll do this thing for you. And then, you know, fill in the blank of what your skill set is in terms of that thing. There is not going to be a shortage of need. And, you know, there may be some really significant change. This may start us really thinking about how we have a national payer, or how at least we have a national essential benefit that doesn't get, you know, watered down by the politics. Who knows what's going to happen? And so I think that, you know, we have to all feel confident that the demand is not going down.
Sure. Yeah, and so and you know, it's been a difficult time for all of us, certainly our providers and customers. But in that, as you're talking about, Sharon, is an opportunity for change. There's the opportunity. Yes, we're going to probably lose a bunch of providers. God knows what the number will be, but we'll lose a bunch of providers because of, you know, Ken Cash or other sorts of things. But there's an opportunity to be more whole person focused, like you're talking about, Sharon. How do we make sure we get care for the whole consumers, but also just for our businesses? Because this whole, we used to think of telehealth as just telehealth for service delivery, but we actually all have our staff at home now too. There's the admin whatever I would call it. You know, do we really need much of a business office anymore?
Let me just say one thing, and I know that I'm talking too much, but that's okay.
That's never happened before.
Never. So in September, I'm going to be doing a presentation as part of the Open Minds, you know, overall kind of crisis management on re-engineering processes. And one of the things that I just find fascinating is things that people say, there's no way we could have ever done this from home. There's no way we're doing this. All of a sudden, we're not doing it anymore and no one's dying, right? So I think this is like the most, you know, wonderful time to do process reengineering, because everything is thrown up in the air, and so you can decide kind of what to catch on its way down.
Well, and we have learned, whether we like it or not, how to manage staff that aren't in the office.
Right.
Whether they be our billing staff, our HR staff, our clinical staff. And we may be wrestling with it. We may have some preferences there. So it will be interesting to see where we land. I did have something I wanted to ask you guys about, and I'm sorry, I'm looking at my notes here. One of the weird things I've run into, and again, Leon, I'm thinking of the staff that have to go to work. If I work in a group home in a setting where there's bed-based programs, you know, we can't do that via telehealth. You know, whether it be a group home for IDD, whether it be you know, doctors and nurses doing injections. There are places where we can't replace face-to-face services. But in particular with some of our wonderful direct care workers that work in settings, the way that the various CARES Acts have worked is that people actually can get paid more if they're unemployed.
Mm. Yeah. Yeah.
And I'm finding that to be, and I don't think that was intended, but I'm finding that to be a challenge for some of my customers who, you know, need folks to work in settings where actually, you know, they would make $900 a week instead of whatever if they stayed at home. I mean, have you heard other folks talk about that, or do you think that's an issue? And again, it's not a long-term issue probably because of the way the funding works, but it has been a major disruption.
Yeah, I'm hearing some of that, not a lot, and that's beyond the behavioral health space, of course. Business is talking about that at large as well. And I think it's sort of a short-term kind of thing. What I have heard, in particular, I'm thinking of one provider I talked with, they were successful in identifying essential staff. And these, for example, in this situation was staff that needed to go out in the community to do a lot of community-based work. So these folks were considered essential. They do a lot of work with homeless folks and with mental health kinds of issues, physical health. So they're managing folks with lots of challenges. So they're essential. They were able to do hazard pay. So they upped their pay to do that. So that's a strategy that they've used. So that's, I don't know, Ken, Sharon, what you might be hearing. Not hearing a lot of difficulty with the unemployment situation and what folks get paid. And that's, like, well, why would I want to come back to work? I mean, I hear business and otherwise, but I'm not hearing providers, at least that I've talked with, dealing with that to a great extent.
I've
Sure.
heard a lot of concern early on about that. I think, and of course, we know that, unemployment or reemployment, that's kind of a state by state basis. And you might look at one state and the pay is very low. Florida has a very low unemployment payout. And our site was overwhelmed. And I think about a quarter of the people who have applied over the last 6 months have gotten any cash up to this point. So everyone has wanted to get out and work. But there are other states that I know of that pay a lot more. I think it does bring us back to this issue of paying direct service staff has enough money to get good, talented staff and hold on to them has been a long-term issue for us.
Sure.
And perhaps this will give us some insights into how we use technology better, maybe, so that we maybe use technology instead of having as many direct service staff. Maybe, this process gives some organizations enough scale so that they can put more money towards direct service salaries and less towards, covering some of those administrative costs they've had in the past. So it may be an opportunity. And even we look at telehealth or working from home versus owning all of it and leasing all the space. Right. This creates an opportunity to be shifting some costs in that area and away from some of the priors that we thought we had, and now we realize those aren't. So it may create some creativity and innovation moving forward.
Yeah, I think that's right on target. I've talked with several CEOs who are already looking ahead and saying, we won't need the corporate office space we had before, because I know when I was still
about that building.
Exactly. And it's not because of layoffs, it's because they recognize we will figure out in this time which positions work best can operate in that environment of working away from home and work remote, as I call it, and those that don't. I know when I was still serving as CEO, it was something we were beginning to do, and we were doing it very carefully. This has just accelerated that whole thing. So two of the folks I talked with, and you're hearing this in business as well, and I'm in touch with the tech world up in the Bay Area. We're going to see a lot of tech companies that will move to their staff to home environments. And so I expect we will see, you already see this in the commercial industry, that we will see open office space. We will see offices that are going to be empty. I expect we're going to see a pretty big change of that.
Sure.
And
I have a couple of people commenting in the chat. Can you hear me? The sound was doing something weird there. A couple of people in the chat saying that they have done a 30% increase in salary for folks that are doing direct care. I know my customer in Kentucky has done the same thing. For the folks that are doing the face-to-face, group home, whatever, the face-to-face care, they have bumped up the reimbursement for those folks.
Yeah, I'm just seeing that here in the chat. Yeah. That's what I'm hearing.
Well, I'm curious, assuming that, let's make the assumption, and I'm going to ask people to type in questions here in a moment. Let's make the assumption that we may be mostly telehealth for 3 to 6 months, until the pandemic situation changes. How does that impact our ability to attract consumers or referral sources to us? I have a whole bunch of people who are suddenly worried about their websites. Their search engine optimization.
Sure.
They're so used to having the local whoever refer to them. Well, the local whoever is at home, and it's not likely to change soon. Where do you think this? Because we're gone virtual for operations for telehealth, but I don't know we've done it so well for the whole front end, the whole referral piece. Any thoughts on that, team members?
I mean, I still feel like it's that partnership. It's partnership. It's make it, I mean, first of all, have a working website. Second of all, have technology that's functional, right? I mean, we have to also worry about, we still have to worry about things like HIPAA and secure direct messaging versus using, cell phones that are unsecured. And, we do live in a litigious society. There are going to be those kinds of things that happen, and there are going to be breaches that come out of this that who knows if the Office of Civil Rights is going to take well, it was during the crisis as, an explanation. So you have to be, I need to say that you have to be careful, but, we haven't made the process of getting services easy for consumers. We've never opened the door wide and let people walk in. It's just never been kind of what we do in the industry. Right. And so we have to figure out what parts of our business are the primary care parts where you want everybody to walk in, and what parts of our business are the specialty parts where you want that referral from the primary care to get there. And I think that's, really the first step. Like, why is it so hard to get in? Why is it so hard to get an appointment? Why does it take 4 weeks to get time with a physician for your first evaluation? We have to begin to use the technology with the work from home to completely open those doors as wide as possible.
But the challenge we have, I agree with you entirely, Sharon, is, I'm doing a bunch of work in Kentucky now. The digital divide is so clear right now. And it's not just for healthcare, it's for kids going to school,
right? Other
sorts of things. There are places where people don't have access to high-speed internet. So their kids can't, their kids can't go to school.
Right.
They can't do telehealth. My customer in Kentucky has given out cell phones so that they could do telephonic care.
Yep.
Because they can't do telehealth, although they'd love to. So that's the other complication I'm seeing in different parts of the country.
So that's why I started out with partnership, right? Partnership somewhere, somehow, whether it's partnering with internet cafes or public libraries or places where people can go and use safely and use technology. I mean, I really do think this is the shift from we sit and wait for people to come to us to we go out and actively try to get people in.
Sure. So listen, what I'd like to do for everyone that's in the audience, there's been a long stream of chat here that I've been trying to keep track of. If you actually have a question for me or the team members, go ahead and type in your question. And I will, if it's a really hard question, I'll give it to Sharon. But type in your questions. We've been talking for 40 minutes or so now, and I've been trying to also look at the stream here. But if you have a question you want to ask us, go ahead and type it in the chat box, and we'll take a look at it. And team members, let's all look for that. But while we're doing that, do y'all think that this intrastate licensure compact around telehealth is going to be around after this? Because that's a big deal, actually.
I think it's really hard to put the horses back in the they run free, and I think that I actually think the decimation of primary care staff is going to be, the American Medical Association and the American Psychological Association, which is the big barriers to getting this happening, are going to want to reduce all their barriers to entry as well. So, I mean, it may not happen right away, but I do think that it's very hard to undo something like that.
Yeah, and I think on top of that, Sharon, the long-term nature of this, if this was just 2 to 4 weeks, that would be different. But given the long-term nature, the payment systems, the legal structure, the cross-state licensing, all this stuff is in place. What I think will change, I mean, there will be some tightening up as we sort of back up and look at this as sort of post-pandemic, or at least starting to come out the other side of it. One of the things that's occurred to me that will tighten up, and that is the confidentiality that's been loosened.
Sure, but Leon, I'm sorry to interrupt. Abby is one of our attendees, and her question, and it's what we're talking about, I'm sorry to interrupt, is, will this suddenly mean I'm competing with providers outside my state or outside the country? I mean, what's your thoughts, Leon?
Yeah.
Don't just say yes.
Simple answer, yes. What will happen, and let me give an example, and it's the long-term nature of this. So my primary care practice, I'm getting every week, I'm getting an email from them. Hey, if you want to get in touch with my doctor, here's how you do it. So they're really moving me now to telehealth as a patient of my physician. So with the long-term nature of this is going to attract, there have been some private equity that's already been involved with this. We're going to see that happen, and we're going to see those who have been doing this, we'll see them expanding, because we did a lot of telepsychiatry where I served as CEO, did it for about 10 or 12 years. And the big piece of it is being able to attract physicians and being able to attract the right physicians. Those that can do that, the infrastructure compared to 12 years ago is basically pretty simple now. And if you have the legal and financial infrastructure there, this is in for the long term, and it will change the competitive landscape.
Now, one of our attendees from Minnesota says she believes that her state is just doing this, particularly the telephonic versus telehealth,
Oh, yeah.
the phone versus what we're doing now, may be retracted, that it was just an emergency response. I mean, do we think some states may respond that way, that they do some pullback?
It'll be different by state, sure.
The difficulty with the United States, I have a sister who works at Robert Wood Johnson.
Don't get too political on me now.
No. And she's an epidemiologist, and we talk a lot about the epidemiology science of this. The difficulty with the United States and why we can't do some of the things that like Germany's been able to do is because we're just so big. And the states' rights issues are issues that make us the United States of America. And so absolutely states will, some states will want to go back. The question is the tsunami of change already reached a point where it's going to be very hard to hold it back?
Yeah, and what I'm concerned about, I do think that we have had a fundamental change in how we deliver services, and I agree that that's not likely to change. It's just about for the right consumer sets. At the same time, revenues for government have gone down enormously. So, in Kentucky, when I was talking to my customer there, where they've closed down, day programs or employment programs, my customer expects that they may never fund them again.
Right, and that's one of the questions
the budget
out there. Yeah.
But one of our other questions here, which I hadn't really thought about, and Sharon, well, actually, I'm going to turn this one to Ken. The question is inpatient care. Both during the pandemic and after the pandemic, do we think there's going to be a major change in the demand for that or the use of that?
I think that certainly in the short term we'll see that. I tend to think that we will begin to see some inpatient as we move forward. I think there will always be a need for that. We may see opportunity, though, to really reduce what we have done in the past, to be quite honest. So it's anyone's guess, but I think it'll be the slow burn of beginning to get back to some of those services that really are best performed in person. And I think that even, we had our discussion about the workplace. I think there'll be something of a hybrid moving forward, but much more openness to be in the community and less focus on bricks and mortar, whether that's providing services or work. And, this whole issue of the states and telehealth and, all health care is so local. But there is just great opportunity. And I think that when we look at telehealth, that's just one piece of it. I know a large primary care provider across our state that is set to do marketing. And I think there are things we can learn by looking at primary care and some of these large organizations, because even expanding our geographic reach within the state is so much more than most of us have been doing. And I see that there is indeed this concern in one of the states about reimbursement. payers have been paying at the set reimbursement rate, and what do we do when we move through the crisis and they begin to say, well, you're not putting as much, it isn't as costly to pay that. And I think we'll have to cross that bridge as well. Our ability to really establish the value of this service we provide, and not just look at cost, but the value of what we're doing in terms of creating a rate that's it's both sustainable and identifies and connects to the outcomes that we want to accomplish.
Yeah, in particular with the inpatient piece, with the providers I've spoken to, there's actually been a decline in some crisis services and demand for inpatient. And I think this goes to, and Sharon, you were talking about this in terms of, we sort of locked down during crisis, but also family members choosing not to reach out or take people to a hospital. I mean, I'll only go to a hospital right now if I break my arm. So, the question is, will that grow? I agree with you, Ken, that there will. I think that our demand for inpatient will actually be steady. It'll be what our population needs. It's just will have gone up or down a little bit. We have a couple other questions here. We have Rick Nance, who's talking a bit about, and he's in Illinois, talking a bit about the mixed response to change, that they see a increased degree of competition for large addiction treatment providers, but there's also this opportunity for rural areas. Any thoughts about what Rick is talking about?
Well, I mean, I'll go back to the one thing this has done is very quickly kind of rip the Band-Aid off the fragility of our economic and healthcare system. And rural neighborhoods, rural areas have been so grossly underserved at all levels of healthcare. There was a great article about how healthcare hospitals in rural settings can't get doctors, so that's been an issue. So this may give us an opportunity to truly expand in these incredibly needy areas. And because the demand is high and the number of service providers are low, we can ask for more money. Let me say that again. We can ask for more money. We can do exactly what Ken was talking about and value our services differently in places where there is scarcity. And I think that we just haven't really done that as a market. I think we've been very much focused on how much does it cost us to do this? Oh, it costs us less, so we're going to get paid less. I really do think that there's some tremendous opportunities in the rural areas where the level of service has been deficient for such a long time, and technology is a way into those environments.
Sure. So, Leon, I'm going to direct a question to you that's from Angela. And again, this has to do with our assumption, whatever it is, about how long will it be till it's safe for us all to be together? Is it 6 months or 9 months till there's a vaccine, or we have, herd immunity, or all these things we're talking about, where we don't have to worry so much being close to one another. And it's specifically about, community mental health support services. These are people that go out into the community, they serve individuals and their families. It needs to be face-to-face care. I mean, what are you seeing happening? What should be happening other than giving them raises and protective equipment? What's your notion about how do we make sure that those more vulnerable folks that are in the community get served?
Right. Well, that's a great question. And I'll go to a situation I'm familiar with that's exactly about that. And that is the provider was able to have these folks identified as the folks delivering the services as essential. So with that, they were able to do hazard pay. They were able to access PPE. This provider was already really advanced with IT. So they have their folks out there with tablets and everything else. They got their EHR on the tablet. They're doing that work remotely. They've been doing that for some years now. So they adapted to this pretty quickly, and they're taking that out to folks in the street. as they were before, but with those additional things, PPE, hazard pay, and those kinds of things. And it's working out well for them. So as to the length of this, that's a real crystal ball. And it as we know, as you were saying, Sharon, not to turn political, but we're very different in different states. So some states are moving quicker than others. We'll see what the second wave looks like. I will say, to use another industry, in the tech industry, they're looking at this as a long-term kind of a deal. Our oldest son just happens to have a tech company up in the Bay Area, and I won't name it, but they are not going to open their offices till at least June or July. And they could, in fact, have them closed through the end of the year. I mean, that's in the Bay Area. That was first in with this in terms of closing up. But I think it is this long-term perspective and how we handle this then going forward, going back to the community-based thing. So why would we not continue to do that? At some point, there may not be hazard pay once we have a vaccine and all this kind of stuff. But why would we not continue to do that, provided the payment systems are there? Does that make sense?
Sure. Rita, one of our attendees, Rita W., I don't know her last name, has also chimed in, because we only have a few minutes left here, about both the challenge and the opportunity of all the things we're talking about are during the crisis. This is what we have to do. We have to manage our cash. We have to keep consumers safe. We have to figure out how to take care of people who need to be taken care of face-to-face. We have to take care of our staff. We have to try to take care of ourselves amidst that, which is challenging for some of us. But we need to be planning for that future. You know, whether it's January, whether it's July of next year, whenever that it is. And I know that's been one of the main things Monica's talking about, is preparing for that post-disruption opportunity and new world we're living in. So since we only have a few minutes left, I'm gonna, because I don't have words of wisdom, I'm gonna ask you each to sort of share you know, what do you give to people today as the most important things to be thinking about? And think of our folks as providers primarily, in terms of both where they are and where they need to be. So I'm going to start with Sharon first.
So I worked in a physical health hospital on a psychiatric inpatient unit. That's one of my first jobs. And we all understood infection control. Mm-hmm. This does not mean you will never leave your house again. It means that we have to have more testing and we have to have more PPE. And we have to understand what infection control means. And then once we have that, we can get back out there. So it's not a matter of we're going to be in our homes for 2 years. It's a matter of we're going to figure out this current bump in the road and we're going to move to the next level. And I think people have to get their teams together and say, okay, let's assume we can get our staff back out because we'll have access to PPE and we'll be able to offer testing. So what are we going to do next? And it's really that kind of envisioning of all the different scenarios that are likely to happen, as opposed to the one scenario, which is very unlikely to happen, which is that for the next 2 years, we're all going to be at home pretty soon, just eating out of tin cans that covered for 25 years, you know. So it's much more likely that we're gonna figure out the PPE, we're gonna figure out the testing, and we're gonna live for 2 or 3 years with this disease, but we're gonna figure out how to do that.
So we can learn from the science we already know, which is
absolutely
it's scary, but we've dealt with infectious diseases. We know the process for dealing with it. Yes, it will change our world and we'll all get through it.
Yep.
So I like that one. I'm going to go to Ken next. Ken, your closing thoughts?
Yeah, just quickly, Joe, I would just say, you know, there's just a great deal of uncertainty. Every state's moving differently. I think one of the biggest challenges we will have as we try to engage consumers again and bring them in and expand, or as we work with staff, getting them in the field, is fear. There's just a lot of fear out there, fear based upon uncertainty, misinformation, valid fear. We want to protect our most vulnerable folks. Certainly all of that. You know, in Florida, our governor has been speaking daily. We have bumped up our testing. our positive testing rate has dropped down to just over 2%. We had been well over 12 to 15% a month ago. So, just getting facts out there slowly, knowing we have to move forward. But dealing with that fear is going to be really important. And we're seeing hospitals opening up now in Florida, 25% capacity. And primary care, and folks are hanging back because of fear. So we're going to have to deal with that fear. I would say, Joe, just very briefly, that from the provider standpoint, I agree with Rita. This is an opportunity to be creative and innovative. There are opportunities to look at your cost structure now using telehealth and redirect what we're doing. There are opportunities to look at your mission and determine, boy, maybe my mission is better served if I combine with a larger or a smaller organization. So I think focusing on mission, focusing on cost structure, thinking innovative and creatively, as we are now forced to do things that we thought might be nice or we'll do that someday, and now we're forced to do that, can position organizations strategically moving forward. Now is the time to consider this.
Sure, and actually, Ken, the notion of fear, I mean, I personally experienced that, which is, I'm afraid to go out into larger crowds, but it fits in with what you've said, Sharon, which is, if we had the tools and we had the understanding, I would be less afraid to go to a restaurant again or any of those things. And Ken's point is, we have to be thinking about our staff, about consumers coming back to, physical settings and other sorts of things. So last, Leon, you have to be brilliant for me.
I need to walk away and go get my brilliance and bring it back.
What are your thoughts as we end? We'll have an opportunity to chat again.
But I agree with all that's been said, Sharon and Ken, and what you've been saying as well, Joe. This has been a wonderful hour here. So I'm going to wrap up with something a little bit different because it's critical, and that is a number of people I talked with said, and this is to CEOs and to leadership, use this as a time to assess your team and to say, how did we function as a team? Where, what worked well, what didn't work well, and do a pretty tough analysis of that. Because those teams that were really good going into this will function well. Those teams with weak points, as we know in crises, that will be exposed. And so it's our work as leadership to work with that and make sure that we improve it. So that was a thought from several folks that I talked with, and I thought, boy, that is just so spot on. So that's on the other side. We'll get through this, all the science, everything else. I'm a little concerned that I see here in Fresno, some folks just not taking the mask seriously and so on. Yep. And so I do get concerned about long-term in a population, how long will they stick with the safety practices? So that's a more other discussion, but just to say, getting back to teams, this is a time to evaluate the team and strengthen it for the path forward.
Sure. Well, listen, team members, thank you so much for being with me on this roundtable. I always learn so much from you, and I hope it's valuable for our audience. But what you said, Leon, is a great way to close what we're doing today. I know this is a challenging time for all of us. It's a frightening time where for us as families, for the people we serve. But what you've pointed out, and other folks have talked about it, is within crisis, there's opportunity. There's that opportunity for change, for reassuring our mission and making sure we're moving forward. So with that, I'd like to end our roundtable today. Again, special thanks to Sharon, Ken, and Leon, and for all the folks in the audience. If you have other questions, just email them to us, and we'll be glad to get back to you. So thank you all.